Pregnant patients with dizziness show up in OB triage every single day. And what's the first thing we do? Order orthostatic vital signs. Almost without thinking. But here's what nobody tells you. Orthostatics in pregnancy? They don't work the way you think they do. So today, we're asking the questions that actually matter. Do they help? Or are we just wasting time and maybe even putting patients at risk? We went deep into the research using AI to find out. And in this video, I'm going to show you 3 evidence-based insights that will change how you think about orthostatics in pregnancy. Plus, one simple, safer alternative you can use starting today. Insight number 1. Pregnancy makes them unreliable. Pregnancy itself changes the vital signs baseline. Heart rate goes up. Systemic vascular resistance goes down. So even without hypovolemia, pregnant patients may show heart rate rises and blood pressure drops. That means orthostatics lose specificity. And here's the kicker. The research on the topic has been conducted almost exclusively in non-pregnant populations. There's only one small study in patients with hyperemesis, and authors concluded that orthostatic vitals might change in hyperemesis, but the sensitivity was too low to use them as a screening tool. So in OB, we're extrapolating from non-pregnant populations, and the physiology in those patients is very different. But even if there's research outside of pregnancy, is that data any good? Insight number 2. The evidence is weak, to say the least. In the emergency medicine literature, orthostatics have been studied for syncope and dehydration. They all concluded that orthostatic vital signs do not reliably diagnose syncope, hypovolemia, or predict 30-day serious outcomes. So when you lean on orthostatics to make decisions, you don't have any evidence to support it. Which leads us to our last insight. Insight number 3. Orthostatic vitals miss the cases we actually care about. Orthostatics have very low sensitivity for moderate hypovolemia. A 1992 study evaluated orthostatic vital signs in 100 blood donors. They checked orthostatic vitals before and after donating 450 milliliters of blood. The authors concluded that the sensitivity is only 17% and that no combination of orthostatic vital sign changes was sensitive enough to reliably detect acute hypovolemia. Only when patients lose more than a liter is when the sensitivity improves, but by then, the clinical picture is already obvious. In dehydration, it's the same story. Poor sensitivity, poor specificity, and no real clinical utility. Bottom line, orthostatics won't catch the moderate losses you're worried about. And if the loss is severe, your patient will already be tachycardic and hypotensive at rest. At that point, you don't need orthostatics. Quick pause before the bonus tip. Are you a resident trying to keep up with evidence-based care, smarter teaching strategies, and the latest in AI? Pathways OBGYN gives you bite-sized education made for the busy resident. Clear, practical, always up to date. Your shortcut to staying sharp without wasting time. Hit subscribe now so you don't miss out. Orthostatic vitals in a pregnant patient who's dizzy may not just be unhelpful, they may increase fall risk. Pregnancy itself alters balance. Weight gain, ligament looseness, spinal shifts, the center of gravity moves. A 2015 study of 4,000 pregnant women found that 1 in 3 experienced at least one fall during pregnancy. So asking a dizzy, at-risk patient to stand for orthostatic vitals? You're adding fall risk on top of the problem you're trying to diagnose. A better, simple alternative is serial vitals at rest and after gentle interventions. Watch for persistence or improvement. In conclusion, you might think orthostatic vitals help, but they're unreliable, especially in pregnancy, where physiology blurs the signal, and standing a dizzy patient adds fall risk. There is no evidence. The data is not pregnancy-specific, and they actually miss the mild to moderate hypovolemia we actually need to catch. Do what works. Track vitals over time. Reassess after fluids, and follow the clinical picture rather than a single stand test. Protect your patient from unnecessary standing and make decisions based on trends, not snapshots. If you want more resident-level teaching on evidence, gray zones, and smarter practice, follow Pathways OBGYN, your shortcut to staying sharp without wasting time.